Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, president of RhAPP, and today we are going to dive into an exciting and rapidly evolving area of rheumatology, the TYK2 STAT signaling pathway and its clinical implications in psoriatic arthritis. Understanding the mechanisms behind targeted therapies is really essential for us to optimize patient care, and TYK2 inhibition represents a novel approach in our treatment landscape. Joining me today to explore this topic is Eileen Lydon, a leading expert in rheumatology who will help break down the science, the latest clinical insights, and what this means for patient management. I also definitely consider Eileen to be a good friend. I've known her for many years, and she's definitely a psoriatic arthritis guru. So with that said, Eileen, do you want to give us a brief introduction?
Well, thank you, Amanda. It is true. We go way back. It's wonderful to be here. Yes, I'm Eileen Lydon. I have been a nurse practitioner at NYU for 21 years now. I primarily work in inflammatory arthritis. In fact, I dedicate a whole day to psoriatic arthritis and then all other types of rheumatological conditions and also some osteoporosis. I have more recently now work in the outpatient spectrum 100%. Before I was doing inpatient as well. So I've had a lot of exposure to working with great people here that have taught me so much over the years.
So incredible. I know when I have a really challenging psoriatic arthritis case, you're definitely one of the people that I think of to go to just because, again, obviously your knowledge of the area and having the psoriatic arthritis clinic, it's just amazing to have you on our faculty. And, again, I think it's important as newer options become available that we really do understand the pathophysiology, because I think that is what truly will help us when we're talking to patients and kind of understanding what the best option for them is. And I think most of us are, well familiar with, JAK inhibitors. We have now several on market. But this one is a little bit different. This pathway is a little bit different within that pathway. So I think let's just start with the basics. Can you give us an overview of the TYK2 STAT signaling pathway and its role in immune regulation, particularly when we're talking about psoriatic arthritis?
Yeah, sure, absolutely. So as you just mentioned, in recent years, our understanding of psoriatic arthritis has dramatically evolved. And it is now known that various cytokines, including those that signal through TYK2, can drive the disease. TYK2 is a member of the JAK family of kinases, and this is along with JAK1, JAK2, and JAK3, and is responsible for mediating signals by cytokines such as IL-12, IL-23, and type 1 interferons, which are involved in the pathogenesis of psoriatic arthritis and psoriasis. So the TYK2 STAT pathway refers to a signaling cascade within the immune system where the enzyme TYK2 activates transcription factors called STATs, which are signal transducers and activators of transcription, which lead to the expression of genes involved in immune responses, particularly inflammation. So let me try to break this down step by step. A cytokine, such as IL-12, IL-23, or type 1 interferon, as I just mentioned, binds to its specific receptor on the cell membrane, causing receptor dimerization. This binding brings TYK2 kinase into close proximity to the receptor complex, leading to its autophosphorylation and activation. Activated TYK2 then phosphorylates specific tyrosine residues on STAT proteins associated with the receptor complex, causing two phosphorylated STAT molecules to bind to each other. Then the STAT dimer translocates to the nucleus, where it binds to specific DNA sequences, promoting the transcription of target genes involved in immune responses, cell proliferation, and differentiation. So I know that's a mouthful, but the TYK2 STAT pathway is crucial for our immune system because it regulates inflammatory responses by controlling the production of cytokines. And the activation of the TYK2 STAT pathway, which is associated with several autoimmune diseases such as psoriatic arthritis. And given its role in immune regulation, several TYK2 inhibitors are currently being investigated for the treatment of immune mediated diseases. And one of the most well studied is Deucravacitinib, which has demonstrated efficacy in clinical trials for psoriatic arthritis. And it is a novel selective TYK2 inhibitor approved by the FDA for the treatment of moderate to severe plaque psoriasis in adults.
Wow. I mean, thank you. I really appreciate you really breaking that down. I mean, I think it's really important that we understand how these things work. And of course, I think you're probably going to guess the next question I'm going to have for you. But how is TYK2 inhibition, how is that different than JAK inhibition? And is that distinction important when we consider our treatment strategies?
So, yes, it is quite different. JAK inhibitors typically target the active site of multiple JAK proteins, while TYK2 inhibitors often selectively target a site other than the active site of TYK2. And this is what allows for a more focused inhibition of specific cytokine signaling pathways, potentially leading to a better side effect profile as compared to broad JAK inhibition. So, in other words, selectively targeting TYK2 inhibitors can specifically modulate pathways involving cytokines like IL-12 and IL-23 while minimizing interference with other JAK mediated signaling pathways. So, due to their broader inhibition profile, JAK inhibitors may have more widespread side effects compared to TYK2 inhibitors, which can potentially lead to fewer adverse events by targeting a more specific pathway.
That makes sense. And that's kind of what I've thought of when I think about TYK2 and, comparing it to some of our other options that are, again, more general in terms of that whole JAK stat pathway. So I guess that kind of leads to this next question about the actual clinical trials. So, do you have information about what was revealed in terms of efficacy and safety of TYK2 inhibitors in psoriatic arthritis? Like, what are the takeaways from that data, that stand out to you?
Mhm. So, there are ongoing studies right now, phase 3 trial in psoriatic arthritis, but the phase two, there was an efficacy and safety trial, which evaluated 203 patients. They were randomized to deucravacitinib 6, 12 milligrams versus placebo, and the ACR 20 response was significantly higher with 6 milligrams and 12 milligram arms versus placebo at week 16. In addition, they did a post hoc analysis that further evaluated the achievement of the minimal disease activity, which we know is really important with our patients. And this showed a greater mean reduction from baseline in all minimal disease activity components versus placebo over 16 weeks. So we have that in the phase 2. And before I talk about the phase 3, I just want to mention the safety. So what they found was that the most common adverse events were nasopharyngitis, upper respiratory tract infection, sinusitis, bronchitis, rash, headache, and diarrhea. There were no serious adverse events and no occurrence of herpes zoster, opportunistic infections, and major adverse coronary vascular diseases or differences versus placebo in mean changes in laboratory parameters. Um, so, as I mentioned, the phase 3 trials are ongoing. And at the end of December 2024, Bristol Myers Squibb announced positive outcomes from two pivotal trials. They were programmed for evaluation of TYK2 inhibitor for psoriatic arthritis 1 and 2, and that evaluated the efficacy of deucravacitinib with active PsA. It involved over 1,400 patients. They were either biologic naive or had prior exposure to TNF inhibitors. So the bottom line here is that this Bristol Myers Squibb is going to present the data from these trials in upcoming medical congresses and engage with regulatory authorities to discuss the results. So, to be determined there. But it sounds promising. In addition, what we know about psoriatic arthritis, we also have 40-year data on psoriasis. There was a study that looked at deucravacitinib versus placebo versus apremilast in patients with moderate to severe plaque psoriasis. They both achieved their co-primary endpoints, showing significant improvements in the PASI 75 and static physician's global assessment at week 16. There was also a long-term extension trial that looked at a cumulative exposure of over 4,000 patients. There was no new safety signals. It remained consistent over the 4 years. Again, this includes rates of herpes zosters, malignancies, MACE, venous thrombosis, and deaths. They all remained stable or were decreased. Now, just as of 1 month ago, in February 2025, there is a long-term extension trial that showed continued improvement over 5 years. So this is just showing us we have, durable response rates in moderate to severe plaque psoriasis in these studies. So, these key takeaways is, first of all, the efficacy in the phase true, particularly, as I mentioned, not only ACR20, but the minimal disease activity reduction is huge, that we're going to be finding out these new results from the phase 3 PsA trials for BMS. And clearly from the psoriasis trials, having up to 5-year safety data is just really reassuring.
Yeah, I mean, it's first of all, our derm colleagues get all the stuff first. It's just not fair. I mean, it's interesting because I have some patients on, that medication from derm, and, it's kind of interesting to see from that perspective of like what kind of efficacy they're getting, and also just even from a safety perspective, again, because that's the biggest concerns that we have, right, about our JAK inhibitors. Obviously, they're amazing medications, and we all use them frequently, but you have to, be cognizant of those risks and talk about those risks with patients. So it's nice to kind of know that maybe there's an option where, that still is targeting that JAK-STAT pathway, or, TYK2 or whatever, but doesn't maybe have some of the same safety concerns that we see with some of our other ones. And that there's now 5 years of data that really reflects that there's no new safety signals, at least from a psoriasis perspective. I mean, that always makes me feel better the longer a product has been out, just in terms of thinking about my own patients, which was going to lead me to my next question, right? So it's great that we understand what's happening in clinical trials and even from an immunology perspective. But now from a practical standpoint, where do you see this kind of TYK2 inhibition fitting into our current psoriatic arthritis treatment landscape? And I guess further, are there specific patients that you think would benefit most from the targeting this particular pathway?
Yeah. So, I mean, first of all, again, even though we have over 17 targeted therapies for arthritis, we continue to see our patients cycle through medications, regardless of all the modes of action that we have. Some people fail, some people have partial response, some people develop side effects. So, first of all, this is needed, right? We know that. Now, one of the key things here is that it's an oral option. And I don't know about you, Amanda, but the vast majority of my patients, when I started telling them about the drugs, they're like, why can't I just take a pill? And so this is many people's preference in general. And, many patients, want that for convenience, but also maybe they're needle phobic. We see a lot of that. Also, I think it's going to be huge for our patients that are, not as adherent, or, want to come back and, let's say, for, IV medications. I think that we're just going to see a better outcome with this medication. Now, so that population of people, and certainly our patients, as you mentioned, with the cardiac side effects, infection risk, and malignancy. I mean, we can now bring in all those patients that we had to counsel a bit more, right, and really weigh out all the options, and give them this really exciting data. So those patients with those comorbidities will be patients we can certainly invite in now. And then also, there was these lack of lab abnormalities, with the JAKs, where we're checking the cholesterol and the liver function and the, neutropenia and stuff. And they didn't find any of those abnormalities. So, that's also another reason for the fact that we won't have to be monitoring these patients as much with lab values, and maybe our non-adherent patients, those people will also be best suited for these medications, because we don't have to be coming in as monitoring them, nor having to worry about people who have issues with their liver or cholesterol to begin with. And also, I just want to point out too, like I find the psoriasis data to be quite good here. And like for an oral medication, psoriatic arthritis, having that along with the arthritis efficacy is needed, especially for moderate to severe disease.
Absolutely. And, it's funny, not funny, haha, because, again, when we both first started, I mean, you've been doing it longer than me, but we just had like very little options for patients back then, I mean,
Yeah.
it was really the TNFs. And unfortunately, if you couldn't take one for whatever reason, I mean, we were really stuck.
Hmm.
A lot of those patients ended up on steroids and, obviously options that weren't the best. And so it's just so incredible. I was diagnosing psoriatic arthritis earlier this week, and I was saying to the patient, because I could tell that, she was kind of upset in terms of, just thinking about having a disease that she's going to have to be on medicines for, et cetera. And I said, really, now is the time to have this disease. I mean, yes, unfortunately, you're going to need to be on therapies. It's not something I can give you that you take one time and then it cures it. But to have so many options, I mean, and a lot of different safe options. I mean, it's
I
just
know.
it
Yeah.
truly. I mean, it's just such an exciting time, I think, to be in rheumatology.
Yeah.
Um,
No, it's funny you say that because I had the same way. Like last week, a new young patient. She was 22. She's so upset, and I almost had a smile on my face. I'm like, no, no, we're gonna be okay,
yeah.
and it's just getting better and better and more precise.
I was just going to
Yeah.
say, I mean, it really does feel like it's precision medicine. I mean, really, and I was kind of telling this to this patient, we really try to have this domain-based approach, right? When we're treating psoriatic arthritis, like, do you have psoriatic arthritis and uveitis, or do you have maybe some IBD? Do you have like, in the fact that we have so many therapies that can target each of those, manifestations is just absolutely incredible. And again, getting back to TYK2, I mean, it really does feel like this is going to hopefully be, I mean, we'll have to see how everything, reads out and, hopefully, the approval, but like, this is going to be a great option. And, one of the things you mentioned was, the lack of, lab monitoring, it seems that we need to do. So what should we be monitoring patients? And this is kind of a loaded question because you obviously do rheumatology. And so you're not derm, but, is there something you can foresee that we're going to need to be monitoring patients that are on this particular medicine?
I mean, honestly, from the data, it doesn't seem like sort of the things we're used to. Even though it's not an absolute, though, I think they do still want us to monitor the quantiferon and hepatitis. But I think, look, we're always wanting to monitor our patients more closely when a new drug comes out too, right? Because we're used to all this stuff, and um, certainly for clinical activity early on, want to make sure that they're going to respond. But um, I think I did read something, even though it's not an absolute, maybe some concern over CPK levels sometimes going up, but otherwise, there's nothing that is out there. In fact, I was going to mention in a few minutes about this consensus panel that, if you want, I'll go ahead with that because this is sort of about the balancing the efficacy and safety. And, this actually just came out in February. This is the review of the safety and efficacy in plaque psoriasis. It was an expert consensus panel that was published in the Journal of Drug and Dermatology. And so they basically are saying that this is a well-tolerated medication, that Deucravacitinib has superior safety over traditional JAK inhibitors. The panel did not find evidence, as I mentioned before, that induced any lab abnormalities. It did not recommend baseline or ongoing lab monitoring. So there you go. So we have this consensus panel saying that, because we know JAK inhibitors, as you mentioned, has been, associated with neutropenia, elevated liver enzymes, dyslipidemia. And it was, just further confirmed that there was no difference in any incidence of serious adverse events. So, the rheumatologist, we should just be aware of this consensus statement as providers right now, because I think we're going to find this publication reassuring, as we see these patients. But I'm one for, like, we have to just kind of wait it out a little bit too. We know it's all about our own personal experience. When we start with a new medication too, we can see what the data shows, but it's what our colleagues are experiencing, and it takes a little bit of time, right? But I do feel very reassured by this, particularly because we have this 5-year safety data with the psoriasis and now this consensus report.
Absolutely. That's awesome. Thanks for sharing that. Again, it's exciting. It's an exciting time, and I'm really excited to see this product hopefully come to market, and be another great option for our patients with psoriatic arthritis. I mean, so I really appreciate, you personally, because again, you are working in a psoriatic arthritis clinic. So you're able, and you'll probably be one of the first, I would assume, users of this therapy. On that note, looking for people that are really trying to stay ahead, is there anything else, any takeaways or clinical pearls that you might, offer considering TYK2 targeted therapies for psoriatic arthritis before we wrap up?
Yeah, I think just really trying to understand the mechanism there, that how, it's very unique and that it does reduce the side effect risk profile there. That the oral option is going to be huge for a variety of patients, including the non-adherent, which I think with psoriatic arthritis, we tend to have a little more anxiety, depression. I find, sometimes patients don't come back as often anyway. So I do think that this will be key for those sorts of people, and that's going to be really important. And then I think finally, just recognizing there's a lot of trials on the horizon right now, the TYK2. So just looking ahead, as we always should be, to see what's coming in the pipeline is going to be important.
Absolutely. Well, again, thank you so much for all of your insight. That brings us to the end of today's episode of RhAPPcast. Eileen, you sharing your expertise on this in the implications for psoriatic arthritis is just crucial because we need to understand it. And again, I feel like there are not a lot of people that I consider to be an expert like you are. So, and obviously a dear friend. So I really appreciate it. Again, is there anything else that you'd like to just say before we close out to our listeners?
I just like what you said before about this idea of, precision medicine. I think that this is an example of something that we could be starting to head in that direction. And it's very exciting. And it's just getting better and better. Yeah.
I totally agree. It really is an exciting time to be in rheumatology. So if by chance you're a listener that maybe isn't in rheumatology, but considering it, please come. Or maybe you're in derm and come to rheumatology. We're just as fun. You just get the derm people just get everything first. But, but again, I think it's just absolutely an incredible time. So thank you again, Eileen. Before we go, I just want to remind our listeners to check out Content Room at rhap.org. You can find all of our latest digital education, including short form videos, journal clubs, and expert insights designed specifically for rheumatology APPs by rheumatology APPs. And if you're looking to expand your rheumatology knowledge, don't forget about A Step Up to Rheumatology, which is really the most comprehensive virtual training course that's available. We're offering it completely free of charge, and there are plenty of additional perks when you sign up. So go to rhap.org to learn more. And lastly, while they had no input on the content of this podcast, we would really like to say thank you to BMS for their continued support of APP education. That's it for today's episode. Thanks for tuning in, and we will see you next time on RhAPPcast.